Hi, I'm Dr. Pathak. I'm a consultant radiologist at Barts Health, Whips Cross Hospital. I'm going to talk to you about MRI of the hip with a slant on sports medicine related pathology. Clinical diagnosis is difficult due to overlapping signs and symptoms, as you probably know. The hip is a complex joint and it's challenging to image too. Now, MRI is the modality of choice. It can evaluate the intra-articular and extra-articular pathology of the hip, and actually this is quite a good way of dividing what we find. You can also use MRI in hip replacements because now the newer MRIs have metal artifact reduction sequences, otherwise known as Mars sequences. I'm going to show you some MRIs of sports-related injuries. Pathology like osteoarthritis, tumours and infection I am not going to include. It's important to stress at this point that you are not expected to make a diagnosis on your own. There is always your friendly neighbourhood MSK radiologist there to help and even treat some of these conditions. Now, in order to appreciate the pathology on an MRI scan, we need to have a basic understanding of normal anatomy. MR arthrography is more sensitive for the detection of intra-articular pathology than non-contrast MRI imaging. An MRI arthrogram is where we inject dilute gadolinium into the hip joint immediately before the MRI. The intra-articular contrast distends the joint, separates the soft tissue structures, unravels the compact labrum, and increases the contrast resolution, all of which help to increase the conspicuity of intra-articular pathology such as labral tears, osteocartilaginous loose bodies, and osteochondral and cartilage defects. Another issue with imaging the hip joint is that it's difficult to image because it's not orientated in the standard axial, coronal and sagittal planes of the body. It's oblique, slightly angled, and there's significant variation in hip joint orientation from person to person. X-rays and CT are good for bone. Ultrasound is good for intervening in the hip, directing and visualizing your needle. But we are going to look at the individual structures that make up the hip joint on MRI. Let's start with bones. This is the MRI of the right hip. This is a coronal sequence, which means front to back. And this is a T1 weighted image, which means that fat is bright, both fat in the subcutaneous tissues here and medullary fat within the bone. Important to get yourself orientated when you look at an MRI scan. You can use other clues like this is the bladder, these are the gluteal muscles over here. But essentially this is what we would see on an X-ray, this kind of orientation. Now the medullary spaces of the normal proximal femurs contain yellow marrow which follows fat signal intensity on all pulse sequences. We can compare it to the subcutaneous fat to be sure. The medullary spaces of the femoral neck, which is what we see here, which is a bit greyer, not as bright. These regions typically contain red marrow, which on T1 weighted MR imaging, which is what we're seeing, is lower in signal intensity compared with normal fat and yellow marrow. So this isn't abnormal, this is normal. It's a sort of reservoir for red marrows. The other thing I would like to bring your attention to are ossific fragments adjacent to the acetabular rim. These are known as os acetabulae. Their clinical significance is unclear, but we see them very often. They are present in approximately 2 to 3% of asymptomatic patients. You will see them on X-rays more than you'll see them on an MRI scan. We think they may represent ununited secondary acetabular ossification centres, possibly incompletely healed acetabular fractures, fragmented osteophytes, or labral ossification caused by prior or repeated acetabular trauma. A relevant history is important. The hip joint itself is a ball and socket joint composed of the femoral head articulating with the acetabulum. Now the acetabulum is actually the junction of the three bones of the pelvis, the ilium, the ischium and the pubis. It is important that we evaluate all of these bones and the sacrum in routine hip MRI imaging, because fractures of any one of these bones can present as vague hip pain. The acetabulum approximates the surface of 2/3 of a sphere, which is incomplete at the inferior aspect where the transverse acetabular ligament crosses. The other type of sequence we have as a mandatory sequence in MRI imaging is the fat suppressed imaging. Now here it is now on the right hand side. This is where the fat is suppressed, so unlike the T1 weighted imaging, the fat suppressed imaging is more sensitive for fluid. Because fat is suppressed, it's dark, so you can see the dark marrow fat is suppressed, the subcutaneous fat is suppressed. You've still got a little bit of brightness here, which is where the red marrow is, because it has less fat. And in addition, this is what we call an arthrogram. So we've injected the hip joint with gadolinium, which is bright, and it envelops the labrum, it envelops the ligaments. So if there's a loose body or a labral tear, it makes it much more conspicuous. T1, where fat is bright. Fat suppressed imaging, where fat is dark but fluid is bright. Let us now look at the cartilage. A horseshoe-shaped articular cartilage called the lunate lines the acetabular concavity, and we see it here as a grey. The black here is the cortex, the grey between the acetabular roof and the femoral head is the cartilage. This is a coronal fat suppressed image with intra-articular contrast. This is a sagittal sequence. In the weight bearing portion of the superior acetabulum at approximately 12 o'clock position, there can be a normal variant called the supraacetabular fossa. We see this quite commonly. Please do not mistake it as pathology. There's no surrounding marrow edema. We would see that as bright on a fat suppressed sequence. Now, assessment of articular cartilage is difficult on an MRI imaging. The curved morphology of the femoral head and the acetabulum, the close apposition of the articular surfaces, and the relatively thin cartilage of the hip as compared to the knee presents difficulties for identifying cartilage defects of the hip. Injection of contrast is mandatory. Here we can see the injection of contrast makes assessment of that articular cartilage of the labrum much easier than, for example, if it was all decompressed with no articular cartilage. Muscles, tendons and bursae. There are many muscles and tendons that surround the hip and allow it to perform a wide range of motions. The muscles of the hip and proximal thigh are generally well delineated from one another by well-defined fascial and fatty planes. Look at this example. These are T1 weighted axial images through the hip joint. The bone is bright, as we've discussed, the bright marrow, and the muscles are of intermediate signal. T1 weighted imaging is best for evaluating muscle bulk and signal intensity. On these images you can see they have a marbled appearance because the high signal intensity fat located between the intermediate signal intensity muscles, much like steak for meat lovers. This fat is interspersed between fibers of individual muscles. A decrease in muscle bulk reflects atrophy. Focal muscle atrophy suggests chronic full thickness tendon tear, but is also consistent with prior severe muscle trauma, chronic disuse, muscle denervation, or chronic corticosteroid use. The arrow over here points to the tendon. Being tightly bound fascicles of collagen, tendons appear as thin bands of low signal intensity on all sequences. There are many important tendon attachments which include the sartorius origin, anterior superior iliac spine, the rectus femoris origin from the anterior inferior iliac spine and superior acetabular rim, the iliopsoas insertion, lesser trochanter of the femur, and the gluteus minimus and medius insertions onto the greater trochanter of the femur. The adductor group of origin tendons insert onto the pubis, and the hamstring group come from the ischial tuberosity, because these are the sites of common avulsion injuries. The hamstrings are the most commonly injured muscles in the lower extremities. The quadriceps injuries are second to hamstring injuries among lower extremity muscular injuries, and the rectus femoris is the most commonly injured muscle in the quadriceps group. There are three important bursae in the region of the pelvis and hip: the greater trochanteric bursa, the iliopsoas bursa, and the ischiogluteal bursa. These bursae may become inflamed because of tendon friction syndromes. Fluid in the iliopsoas bursa, however, may be a normal finding because it communicates directly with the hip joint in 10 to 15% of individuals. The iliofemoral, ischiofemoral, and pubofemoral ligaments represent thickenings of the joint capsule that reinforce and stabilize the hip joint. They are named for the bones that they connect to. The Y-shaped iliofemoral ligament is one of the strongest ligaments in the body. It reinforces the anterior hip capsule by limiting anterior translation during extension and external rotation. This is, on the left A, T1 axial weighted imaging of the right hip joint. It shows this low signal intensity structure, which is actually a non-distended iliopsoas bursae. It's between the two arrows. Now here on the right is an axial image again, but it's fat suppressed because the fat is dark, and it shows a small effusion, which is the bright fluid because it's fluid sensitive. It shows some synovitis by this arrow, so that fluid is actually a little bit more dense, which is sort of synovial hypertrophy and debris. And we have here distension of the bursa, the iliopsoas bursa. So on the left it's nice and thin and non-distended, and on the right you can see fluid really blowing it up. This is an example of some of the ligaments. This is the transverse acetabular ligament. As I'd said before, that the acetabular cartilage is incomplete inferiorly, where it is completed by a transverse acetabular ligament, and we can see that the beginnings of it here on a coronal sequence, and this is an axial sequence, and we can see that transverse acetabular ligament going across. These images are demonstrate the hip ligaments. We have contrast in the hip joint, so this is sort of going from front to back. We can see the femoral head, we can see the head and neck, and then we can see the posterior aspect of the hip joint. The bright contrast really dilutes it and distends it to make these ligaments more conspicuous. You can see the iliofemoral ligament, which is this very big, thick and strong ligament here laterally. It extends from the anterior inferior iliac spine to the femoral neck, and you can see it's one of the most important stabilizers of the hip. The labrum is a low signal intensity fibrocartilaginous structure that is attached to the acetabular rim. The sensitivity of MR arthrography for the detection of labral tears is at least 90%. Here we have an axial fat suppressed MR image after the injection of intra-articular contrast. We can see that the joint is distended. We can see it's fat suppressed because the marrow is dark. It shows the labrum as a low signal intensity structure attached to the acetabular rim, and this is the solid arrow depicting that here. The free margin of the anterior labrum is sharp. We can see that sharpness compared to the free margin of the posterior labrum, which is here. You can see it's slightly blunted. Now here, anterior to the anterior portion of the labrum is the iliopsoas tendon. This should not be mistaken for a tear. Nor should this small cleft. This is the sublabral recess. It is a normal variant. Here is also another normal variant. This is a bit lower down and it looks like a tear because you can see contrast going through it, but it's actually the origin of the transverse acetabular ligament, which has a normal cleft here. Again, here's another normal variant. You might mistake it for a tear, but it's actually the joint capsule, and this is the anterior labrum, and you have a normal perilabral recess here. So it's incredibly difficult to interpret labral tears even on an MR arthrogram. Nerves. On MRI imaging, nerves appear round or oval in cross-section with a stippled appearance. The stippling appearance represents individual nerve fascicles separated by variable amounts of fat. Larger nerves, such as the sciatic nerve, have a striated appearance when imaged longitudinally. So this on the left is an axial, so a bottom to top sequence of the sciatic nerve. What we're seeing here is the ischial tuberosity, the hamstring origins, and we've got the right femur here, and between the two are this oval stippled low signal structure, which is the sciatic nerve. You can see its proximity to the hamstring origins, which it can become involved with if there's inflammation of the hamstring origin. Now this image on image B is a coronal section through the hip, and again here we have the ischial tuberosity, which is bone, so fairly bright. This is the low signal hamstring origin, and then emerging here is the sciatic nerve. You can see it's striated in appearance. It's between the two arrows, and it passes through this little foramen here, which is a sciatic foramen. Now this is another axial, so bottom to top image through the hip joint. And there's the femoral head, here's the acetabulum, it's a T1 weighted image, and the black arrow points to the femoral nerve. It lies anterior to the ilius, so as it exits the pelvis through the femoral canal, and it innervates the quadriceps muscles and provides cutaneous sensation to the anterior thigh. You can see it sits in the femoral canal, lateral to the artery. Now this is an interesting nerve. It's very faint, but you can see a striated appearance. What nerve do you think this is? It's an axial section, T1 weighted section. This is the pelvis, this is the acetabulum. You can just see the top of the femoral head. So this is actually the obturator nerve. It passes posterior to the common iliac arteries. It travels along the lateral wall of the pelvis and exits the pelvis through the obturator canal, where it innervates the obturator externus, the adductors, the gracilis and pectineus, and occasionally it can be involved in pelvic pathology, or sometimes a little ganglion or cyst can impinge upon it. Okay, so now we've discussed the basic normal anatomy, let's have a look at some of the pathology. We're going to divide pathology into intra-articular and extra-articular causes. And when I say intra-articular, I'm not going to talk about degenerative hip osteoarthritis or infection or synovitis, which are all intra-articular. I'm going to concentrate mainly on the sports injury type pathology to do essentially with the labra and the phenomenon called femoroacetabular impingement. We'll start with the labra. The acetabular labrum is an important structure within the hip that provides joint stability. Now, labral abnormalities are a significant factor in the development and progression of degenerative joint disease, so that's why it's important to pick these up early, because you can modify the progression of hip osteoarthritis if treated. Those patients with labral abnormalities may have acute or chronic symptoms, and they're widely ranging intensities and locations and duration, so it's a nightmare to diagnose clinically. The findings are highly variable, and there are numerous regional anatomic structures that can make the clinical evaluation very difficult. MR arthrography, i.e. injecting dilute gadolinium into the joint, is the imaging technique of choice for the detection of acetabular labral tears. Now we see the labrum here. Now the labrum is this very thin blue ridge. It's an incomplete fibrocartilaginous ring around the acetabular margin, and it's completed by the transverse acetabular ligament inferiorly. The acetabular labrum has a limited blood supply, and the majority of the labrum is avascular. Why is that important? Well, it's important because if you have an injured labrum, it has limited potential to heal. What does it do? It's got several important functions, including the containment of the femoral head during acetabular formation and stabilization of the hip by deepening the acetabulum. You can see this ridge just deepens it. It makes the socket or the cup deeper, and that keeps the femoral head contained. Now, labral tears often occur in young patients with normal x-rays, so difficult to diagnose, and actually they occur a significant amount in patients with no history of prior trauma. Athletic activities that involve repetitive pivoting movements or repetitive hip flexion are recognized as additional causes of acetabular labral injury. More commonly, the symptom presentation is subtle. It's characterized by dull activity-induced or positional pain that fails to improve over time. Patients often describe a deep discomfort within the anterior groin or lateral hip proximal to the greater trochanter. The really important symptom is clicking. Clicking can be caused by many things, but clicking and instability suggest an acetabular labral tear. Let's look at the MRI appearances of labral tears. The causes of labral tears can be degenerative, dysplastic, traumatic, idiopathic, or even impingement. They're commonly seen after femoroacetabular impingement. This classification by description would include frayed tears, where there is irregularity of the free edge of the labrum substance, partial thickness tears, full thickness tears, and complex tears. The questions we should ask ourselves are: is the labrum triangular in shape, or is it rounded, thickened, distorted, or irregular? If it's distorted or irregular, this is considered a labral tear. The second question we should ask ourselves is to see whether does the contrast, the intra-articular contrast, extend into the labrum, indicating a tear, or if it extends between the labrum and the acetabulum, indicating labral detachment. And then the third question is the signal intensity within the labrum increased? If it is, it suggests mucoid degeneration. Another thing we should keep an eye out for is a paralabral cyst. A paralabral cyst is almost always associated with a labral tear. Let's look at these images more carefully. So we'll start with this one over here. So let's orientate ourselves first. A is a coronal sequence, so front to back. This is the femoral head, this is the acetabulum, and the arrow is pointing to the labrum. B is an axial sequence, so from feet to head. Patient lying down looking, and you're looking upwards. This is the femoral head, this is the acetabulum. What we see is a partial thickness labral tear. You can see the bright gadolinium extending into this little gap over here, which is a partial labral tear. We can see it again, it's irregular, it's not sharp like the posterior labrum. Look at this posterior labrum, it's this triangular shaped dark structure. Look at it anteriorly, it's got this intrinsic high signal in it, it's not particularly well defined. This is a labral tear unless proved otherwise. This is a sagittal sequence, so this is actually left to right. And this is an axial sequence. You can see that it's fat suppressed because the marrow fat of the bone is suppressed, and we can see that there's some bright stuff within the joint which is intra-articular contrast, so this is an MR arthrogram. We can see that the gadolinium, the intra-articular dye, is traversing across the labral base just over here. Can you see how it seeps across this labral base here, this oblique bright signal? And it also goes around this acetabular rim, so it just leaks forward here as well. You can see it here, it goes all the way across, and there's no continuity of this dark periosteal layer anteriorly, so this is a full thickness labral tear. Now let's orientate ourselves for this third pathology. This first image, A, is a coronal image, so front to back. It's fat suppressed because the marrow fat is dark, and we know that there's intra-articular contrast in there because the joint has got bright contrast signal within it. Now what we're seeing is really that the labrum is just not particularly well defined. It's not that sharp triangle that it should be. It's all a bit irregular. It's all got this intrinsic high signal within it. It's a bit frayed and macerated. You can see here on the sagittal sequence, you know, it's just the labrochondral junction also has got high signal within it. And here on the axial sequence, that sharp triangle is gone, and you've just got this irregular high signal. This is contrast seeping across really a degenerative labrum. It's quite significantly degenerate. It's a complex degenerative tear. This is how we would describe it. The morphology is distorted and abnormal, and this gadolinium signal within the tear. Now let's orientate ourselves to this image here. So this A again is a coronal image. B is a sagittal, C is an axial. Fat suppressed, we know that there's intra-articular contrast. So once we've got our orientation, we know our anatomy, we can concentrate on the labrum. Here we see contrast seeping across the labrum, and here we see this little bright signal structure. It's a tiny little bulbous bright signal structure, and it's emanating from the irregularity of the labrum. It's not contrast. This is a small paralabral cyst, and paralabral cysts occur when there are tears of the labrum, and here is the tear. You can see contrast extending across the entire anterior labrum on this axial section. So these are labral tears. They can only really be diagnosed with intra-articular contrast. Now let's look at femoroacetabular impingement. Now, femoroacetabular impingement is increasingly recognized as a pathomechanical process that can lead to hip pain and osteoarthritis in young adults. Femoroacetabular impingement occurs as a result of abnormal contact between the proximal femur and acetabular rim that we previously talked about, and this is caused by morphological abnormalities affecting the femoral head-neck junction. In most cases, a combination of femoral and acetabular abnormalities is identified. In addition, hypermobility of the hip can lead to femoroacetabular impingement, even in the setting of only slight osseous abnormalities. It's a combination of repetitive microtrauma from impingement of the femoral head against the acetabulum, and this causes degeneration of the acetabular labrum. As well as progressive damage to the adjacent articular cartilage, it can lead to osteoarthritis of the hip. Early diagnosis of femoroacetabular impingement before significant cartilage loss is evident is therefore of paramount importance, because it can prevent the onset and progression of osteoarthritis. Now, cam impingement is caused by abutment of an aspherical femoral head against the acetabulum during hip motion. The cam deformity refers to this osseous excrescence at the femoral head and neck junction, otherwise known as an osseous bump or a scar. So when you have the extremes of movement, this causes abnormal forces from this osseous bump to act on the acetabular cartilage and subchondral bone, leading to damage to the labrum. So A is normal. This one here is an axial section, femoral head. There's the acetabular cartilage here. You can see it over here. This is the bone. There's no osseous bump at the femoral neck. Now B is where we get an osseous bump, you can see that the offset angle is decreased, and what you've got is reduced femoral head and neck offset. The clearance is reduced, and when you move that hip, the bump will hit that labrum and cause premature degeneration or tears. Now let's look at C. This is excessive over-coverage of the femoral head, otherwise known as pincer type impingement. You can see this is nice and shallow in A, but in C the acetabulum is a little bit more prominent, and it overcovers this femoral head. And in the same way, you get impingement every time you flex or move that hip. The bone will hit the cartilage and cause problems. And this is actually the most common. It's mixed, so you've got a little cam type deformity here with an osseous bump, and you also have acetabular overcoverage. Here we have an X-ray showing typical cam type deformity. You have this osseous bump at the lateral aspect of the femoral neck, and every time this patient flexes, this bump will hit this cartilage and the bone. Here's an MRI, so let's get our orientation. We've got a coronal here. A is a coronal section, fat suppressed, and we can see this osseous bump again. It shouldn't be there, it's a morphological abnormality. And what we can also see is a little bit of brightness underneath it, which is bone edema, because it's repetitive microtrauma basically. Every time the patient flexes the hip, it hits the acetabulum. Let's get our orientation for B. This is an axial section, so top to bottom. And there's your osseous bump there, a morphological abnormality. And you can imagine when that patient flexes his hip, this will impinge on the acetabular margin. Here we have acetabular overcoverage. So these are both coronal sequences, and what we have is secondary osteoarthritis. Unfortunately, there's a full thickness tear going across the acetabular labrum, secondary to mixed cam and pincer type deformity. You've got edema underneath, you've got edema of the labrum, and you've also got some bony proliferative change, which is this brightness over here. This is secondary to degeneration. This is essentially osteophytes. Here is acetabular overcoverage. Again, you've got the acetabulum really extending way over 2/3 of the superior femoral head convexity. When you go down axially, you can see it's really covering that femoral head, and it's resulted in this labral tear. We can see the contrast extending across the labrochondral junction. Okay, so now we're going to look at extra-articular causes of hip pain, and we're going to concentrate on ischiofemoral impingement, tendon causes of hip pain, and the incorrectly named sports hernia. Let's start with ischiofemoral impingement. Now, ischiofemoral impingement is a syndrome defined by hip pain associated with narrowing of the space between the ischial tuberosity and lesser trochanter impinging the quadratus femoris muscle. Patients with ischiofemoral impingement present with chronic pain in the groin or buttock, usually without precipitating injury. The pain may radiate distally to the lower extremity because of the proximity of the quadratus femoris muscle with pressure effect on the adjacent sciatic nerve. Plain films are often non-contributory. MRI is the standard imaging method to diagnose ischiofemoral impingement. It shows edema and deformity of the quadratus femoris muscle belly at the site of maximal narrowing. In patients with long-standing impingement, quadratus femoris muscle fatty infiltration and atrophy may be present. Let's start with this 54-year-old who has a normal quadratus femoris muscle. This is the ischiofemoral corridor. These are the measurements between the lesser trochanter and the ischial tuberosity, A and B, and they appear entirely normal. Here is a sagittal image where you can see the sciatic nerve and the quadratus femoris muscle. Look how close they are together. They're very, very close. The squiggly line is the sciatic nerve, and this thick arrow is the quadratus femoris muscle. So you can imagine when there's inflammation of the muscle secondary to impingement, how the sciatic nerve can get affected. Let's move on to this axial section of a hip area where you've got your femur here, you've got your lesser trochanter here, which is the dark protuberance here, and you've got your ischial tuberosity here, and between the two is the ischiofemoral corridor, and you can see the quadratus muscle going between them. This is a fluid sensitive sequence, so you can clearly see the inflammation around the quadratus femoris muscle. The quadratus femoris is deformed, and you've also got actually this very low signal structure coming off the ischial tuberosity, and these are the hamstring tendons, and you can see they are quite inflamed as well. So it's a complex, isn't it? The quadratus femoris is inflamed, it's chronic, and then the inflammation basically spreads to the right hamstring origin. Let's move over to these images here. So A is a coronal image, and B is an axial image. A is T1 weighted, so fat is bright. B is fat suppressed, fluid sensitive image, and you can see that there's this mass lesion in the ischiofemoral corridor. There is the lesser trochanter here. There's the ischial tuberosity here. This is the ischiofemoral corridor, widened actually rather than narrowed. So that was a bit of a red flag. Normally the ischiofemoral corridor is narrowed, and that's what causes the impingement. And actually the fluid signal isn't quite fluid. It's not uniformly bright. It has this internal matrix to it. This was a 65-year-old. This lesion was biopsied, and it showed myofibroblastic sarcoma. So this was tumour, and it was causing mass effect, and it had been mistakenly thought of clinically as ischiofemoral impingement. Here is another example of ischiofemoral impingement. Again, let's orientate ourselves. It's an axial section. This is the femur, this is the ischial tuberosity, these are the hamstrings. It's a T1 weighted image, so it's not fluid sensitive, but we can, despite that, we can clearly see that the ischiofemoral corridor is narrowed and the quadratus femoris muscle is impinged, it's deformed. And what's interesting here is you've got this fibrillar structure here, which is a sciatic nerve, very close to the inflamed quadratus femoris muscle, and this patient had symptoms going down the leg because of irritation to her sciatic nerve. And we can do this as well, we can inject it. So this is a CT now, so we put a CT guided injection of local anesthetic and steroid into the ischiofemoral corridor to reduce the inflammation and hopefully deal with the symptoms. So as radiologists we have the means to treat these if conservative therapy fails. Okay, let's look at the extra-articular structures known as the tendons. Tendon origin hip pain can be characterized as anterior, lateral or posterior. Peritendinitis represents the earliest injury and manifests itself as increased T2 signal around the tendon. So let's have a look. So here we have the hip joint again. There is the coronal T1 weighted images, fat is bright. You can see some thickening of the gluteus medius tendon. When we look at the fluid signal structure, which is fluid signal sequences, which is the one on the right, B, you can see this is an axial image, and let your eyes be drawn to the fluid. There's fluid enveloping the gluteus medius tendon, which is consistent with peritendinitis. Now the important thing about tendons is that you may send a patient for an MRI report, an MRI, and the report might come back as tendinopathy, but tendinopathy is common and maybe asymptomatic, so it's up to you to determine whether what the report says ties in with how the patient's symptoms are. So treat the patient, not the pictures, is an age-old adage in radiology. Here is there's further examples of tendon abnormality here. We've got a tear of the tendon, so you can see high signal within the hamstring tendons. This tendon itself is swollen. This is the axial. Remember the ischiofemoral corridor. This is the hamstring tendon. This again is the hamstring tendon. It is a tear, but it's a partial thickness tear because your tear is within the actual tendon and there's no retraction. This is the sagittal image. You can see the tear. Let's have a look at some more examples of tendon abnormality. Now this is a full thickness tear. This is again the gluteus medius tendon on the great trochanter, which is bare. It's just got this rim of irregular fluid, so the tendons basically come off. We can see the fluid here again, and we can see the bareness of the gluteus medius tendon insertion. And this is chronic, so this is a T1 weighted image, coronal. Now the star is actually on fat. This is muscle, this is tendon, there's a big gap between the two. This is basically a full thickness tear, frayed stumps and atrophy, the fatty atrophy you can see of the gluteus medius. Now this is quite interesting. This is low signal within a tendon. So this is an axial, fat suppressed, fluid sensitive sequence. So the fluid, you can see lots of fluid, really lots of inflammation really around that tendon here. But what we're seeing now is just very low signal structure here. And what is low signal on MRI? Well, we know tendons are low signal on all sequences, but the other thing that's low signal on all sequences is calcium. This is actually calcific tendinitis, and it's really painful. It causes a really severe inflammatory reaction, and it's painful in the hip tendons, it's painful in the shoulder tendons. And it was confirmed with a CT actually, and you can see this. CT is very good for calcium, not so good for soft tissues, but you can see this deposit of calcium within the tendons themselves. And actually we treat these, we can barbitage them. Barbitage is basically a way in which we, under ultrasound guidance, stick a needle in there, break it up, suck out the calcium and replace it with steroid. So bear us in mind if you come across any of these. So let's go back to characterizing hip pain, tendon origin hip pain as anterior, lateral or posterior. Let's start with anterior pain. We'll start with this x-ray here. This is a 14-year-old runner on the running team. He experiences a pop while running. We can see here that the iliac crest apophysis is avulsed and displaced. Look at the arrow pointing to this bit of calcium here. It's the rim of the apophysis. It's been avulsed essentially. It's not there on the left. Use symmetry. So we MRI'd this patient, and you can see quite clearly how there's a large fluid filled gap, and there's a sort of apophysis which is avulsed off, and there's lots of edema extending around the muscles. Here we are again. You can see that the avulsion has gone here. You can see a nice apophysis here, and this is an axial, by the way, so iliac bones, sacrum, pelvic structures, anterior, posterior, left, right. Here's a nice apophysis sitting here on the ASIS on the left. Here it's deficient, it's gone, it's replaced by edema extending into the muscles. And here it is again on the sagittal. You can see it's just been avulsed off. Here we talk about abnormalities related to the iliopsoas tendon. Abnormalities of the iliopsoas tendon include tendinopathy, tendon tears, the internal snapping hip, and iliopsoas tendon impingement. Now, the iliopsoas compartment is an elongated extraperitoneal space that extends from the posterior mediastinum to the hip joint. You have a composite iliopsoas muscle which exits the pelvis under the inguinal ligament, and its tendon inserts onto the lesser trochanter. Here we have an axial section, and B is a sagittal sequence. They're both fat suppressed, and they're both fluid sequence, and I want to draw your eyes towards the left iliopsoas tendon. This was an 80-year-old woman who presented with acute onset left hip pain, and the iliopsoas tendon and muscle are completely torn and retracted, and you can see the tear here. It's pulled backwards. This is the tear here, this little bright area and this gap between the two. Now, the important thing is, on the axial you can see the retracted tendon stump here, which is this black bit here. There's the iliacus here, there's the retracted stump, and this thing surrounded by inflammatory fluid is the femoral nerve. And she was getting neurological symptoms because of the femoral nerve's proximity to the iliopsoas tendon. Let's talk about the internal snapping hip syndrome. Snapping hip refers to a broad range of pathologies that present with pain and an audible snap. There are three categories of snapping hip: external, which is related to the iliotibial band and or the gluteus maximus; intra-articular, related to intra-articular processes, but we're concerned with the internal snapping hip syndrome, which is related to this structure here, the iliopsoas tendon. You can see the iliacus muscle and the psoas muscle, and they have a joining distally to form the iliopsoas tendon. The tendon undergoes normal medial translation as the hip goes from flexion to extension. So you can see it's flexed, and when it extends the tendon goes medially. So here it's lateral and here it's medial. And what happens is that it can snap over this iliopectineal eminence, which is what the star is, a little bony protuberance here. It can also snap over the femoral head, and this snapping can be palpable and can be voluntarily reproduced. If your patient comes in and says my hip snaps and shows you, you can hear it, you can feel it. If you do a dynamic examination, flexion to extension, you can feel the snapping. There's no MRI imaging specific findings, but you can see the snap of the tendon, the jerk of the tendon on ultrasound with dynamic ultrasound. And you can also inject it under ultrasound as well, because that can help with the diagnosis. Okay, let's talk about apophyseal injuries of the origin of the rectus femoris. So, apophyseal injuries at the origin of the rectus femoris are well known in young footballers, where they have forceful kicking requiring extreme hip hyperextension followed by forceful hip flexion and knee extension. The avulsed fragment is commonly small and can be difficult to detect on plain X-ray. Here we have an axial image, so again fat suppressed, fluid sensitive, and you can see lots of edema around the apophysis at the origin of the rectus femoris. Here we are again. This is a coronal image. This is the edema around the apophysis. This is actually retracted. It's been avulsed, so you can see it's been pulled back. Here again, this is a sagittal. You can see really a lot of edema around the rectus femoris origin. And this patient comes back after a while, and you can see the calcified apophysis there. So part of it has been pulled off, and it almost looks like an exostosis. There's actually an avulsed, chronically inflamed apophysis. We can now talk about lateral pain. Now, lateral pain is often from peritrochanteric pathology. and we used to call it greater trochanteric bursitis, but it's now called greater trochanteric pain syndrome, otherwise known as GTPS. It's the preferred term for the spectrum of abnormalities of the hip abductor tendons, that's gluteus medius and minimus. Remember, the maximus doesn't insert onto the greater trochanter. And also the bursa is now collectively known as the peritrochanteric bursa. The most common presentation is that of chronic persistent lateral hip or buttock pain exacerbated by lying on the affected side, prolonged standing or getting up from sitting. Half of the affected individuals complain of lateral thigh pain that radiates through the knee. They're tender to palpation over the greater trochanter, and because the hip adductors play an important role in gait and hip joint stability, affected individuals can present with a Trendelenburg gait as a result of weak hip abduction. The abductor tendons can be affected by peritendinitis, tendinopathy, and tendon tears. So here's the bursa. This is the coronal image of both hips now, so the whole pelvis. You can see femoral head, fat suppressed, fluid sensitive, and this is the greater trochanteric bursa here. You can see the bursa is, well, it's peritrochanteric bursa. It's fluid filled, and the actual tendon itself is inflamed. This is long-standing peritrochanteric bursitis with tendon inflammation leading to tendon weakness, scarring, and tearing. So the greater trochanter is bare because the tendon is basically degenerated and torn off. Okay, now we can look at posterior pain. Posterior pain is less common than anterior, lateral and medial pain. It's most frequently secondary to lumbar spine disease or sacroiliac joint dysfunction, so keep that in mind when patients come in with posterior pelvic pain. The other cause is proximal hamstring pathology, including tendinopathy and tendon rupture. It's less commonly encountered, but it's becoming more frequent because we're a bit more active and tendons generally deteriorate or degenerate as we get older. Injuries to the hamstring myotendinous unit are common, particularly in athletes, and it normally affects the long head of biceps femoris. They're normally conservatively treated and do well, but the most serious hamstring injuries that might require surgery are tendon ruptures. So you know the hamstring muscle group consists of semimembranosus, semitendinosus, and the long head of biceps tendon. They play a role in knee flexion and in hip extension, and the hamstring muscles arise from the ischial tuberosity. Now here is the ischial tuberosity, and here is the hamstring tendon. And we can see actually this is slightly thickened. It's a tendinopathy. It's got a bit of edema around it, and we can see it here. It's essentially three tendons: semitendinosus and long head of biceps, which is the main tendon, and semimembranosus posteriorly. Here is a rather extreme example of a hamstring tendon rupture. Here is the bare ischial tuberosity. Here is the myotendinous unit. The tendon is retracted completely. This is where the sciatic nerve runs, and you can see all the edema around the sciatic nerve, and that's going to be causing a lot of sciatic nerve irritation. Here we have the bare ischial tuberosity, where the hamstring tendon has ruptured off it. And finally we come to sports hernias, which are very, very common these days. Think about it when you have, young adults, athletes with groin pain, and the sports hernia is a misnomer. We shouldn't really be using that term. We should be calling it athletic pubalgia. It's more encompassing, because actually it isn't a hernia. There is no hernia. It's been really difficult to diagnose for years and years. I remember when I first started, people would diagnose these using x-rays or simply a clinical history and then operate. But actually the MRI is really, really useful to confirm the diagnosis and exclude other causes of groin pain. Now the groin region is commonly injured during activities involving rapid acceleration, twisting and lateral motion. Such sports-related injuries were often called sports hernias, but the reality is that they can be very specific and very different entities, and MRI is the way to identify what they are and to treat them appropriately. So often it's the rectus abdominis adductor aponeurosis injury that's most frequently encountered on MRI. These involve the distal rectus abdominis and the adductor longus origin, and their relation to the pubic tubercle periosteum. And you can see the inflammation quite clearly on MRI. You can get interstitial tearing of the rectus abdominis insertion, and you diagnose these by using a symmetry as your tool, looking at left versus right. So let's have a look at what they look like. So these are a sequence of MRIs. These are all fluid sensitive sequences, and this is the bladder, and this is already, so you haven't seen this before on your previous on the previous imaging, because we're looking now at the pubic symphysis, the superior pubic rami. Here's the bladder. This is coronal. This is a normal looking pubic symphysis. This is B, which shows it's a sagittal image. So sagittal basically is from left to right. We can see the bladder, we can see the symphysis pubis, we can see the rectus abdominis muscle and the aponeurosis, and we can see a tiny bit of edema here at the aponeurosis, which is probably micro tearing, one of the most common causes of athletic pubalgia. This is C again. C is a coronal image, symphysis pubis. From the inferior aspect of the symphysis pubis, you have the origin of the adductor tendons. On the left they're intact, on the right there's a tear. So this is another cause of athletic pubalgia, tear of the adductor origin muscles, which is adductor origin tendons, which is very common in footballers. Again, a sagittal view showing that edema at the aponeurosis. Here's scarring here, so the adductor origin here is now thickened. It's a low signal structure, it's thickened, scarring on the right. Here the arrow points to an absence of adductor tendon at its origin, indicative of a tear, and it's pulled back. So there's a gap here, so it's an left adductor origin tear. Here it is, a much bigger example of it. And here is severe edema of the distal rectus abdominis, really a lot of inflammation. That's really been pulling quite chronically for whatever sports reason, causing lots of inflammation. So a lot to take in, but the take-home point here is that the sports hernia has many different causes. Here's what we call micro tearing of the adductor origin tendons. You have your symphysis pubis here, you have a bit of edema here where the adductor origin is, and you've got micro tearing. Here it is a bit more extensively. It's called a secondary cleft sign. You may have heard of it before, because it's a cleft. It's a cleft that runs from the symphysis pubis across the adductor origin. These do quite well with rest and steroid injection, and don't necessarily require surgery. Here is a more central lesion. It's not left nor right, it's adjacent to the adductor origins, but it doesn't involve them. Here on C it's very extensive, really going from left to right. This is all fluid signal. This is a pubic plate injury. Again, a sports injury. Now this is, let's orientate ourselves, see if we can work this out. This is an axial image through the pelvis. This is your symphysis pubis, your left and right parasymphyseal bone, and this is the coronal, so of another patient, but similar pathology, left and right parasymphyseal bones, bladder over here. Fluid sensitive sequence, so your eyes are drawn to the bone here. There's lots of marrow edema left and right side. This is parasymphyseal edema. There's a little bit of fluid within the symphysis pubis. Here, this is an example of osteitis pubis. Okay, you've got subchondral bone marrow edema. This is chronic osteitis pubis because now you've got subchondral cyst formation. So we come to the end of the lecture, and the take-home points are that hip pain is very, very difficult. I mean, we haven't even talked about osteoarthritis or infections or bone lesions, but to diagnose it, it's very difficult on clinical examination. X-rays are good, MRIs are essentially the gold standard, and you're not expected to make these diagnoses yourselves, and actually your radiologist can help you not only diagnose the pathology but treat the pathology as well, because we can reach most of these places under image guidance with a very thin needle and inject steroid or anesthetic just to confirm or refute the diagnosis. Anyway, thank you for your